following lecture is aimed for dental students, interns, junior trainees, junior residents of oral surgery and oral maxillofacial surgery, as well as junior residents of other dental specialties. I also dedicate this lecture to my fellow colleagues and dental practitioners of several dental specialties all over the world. May you all benefit from it. In memory of my late parents, may Almighty merciful God rest their souls in heaven and peace. Please allow me to give a brief bio about the speaker. My name is Mohammed Al-Shulkami. I'm a professor of oral and maxillofacial surgery at the Faculty of Dentistry, Suez Canal University in Ismailia, Egypt. This lovely city, which lies around 120 kilometers to the eastern of the capital Cairo in Egypt. It was named after the late great ruler of Egypt, Khedive Ismail, the one who did the opening ceremonies of the Suez Canal in 1869. I'm also the professor and the supervisor of the Oral and Maxillofacial Surgery Department at Faculty of Dentistry, Sinai University, Kantara campus in Ismailia. I also worked as a part-time associate professor at MIU University and MSA University for several years. I'm a visiting professor at the Faculty of Dentistry, Beirut Arab University in the Oral and Maxillofacial Surgery Department in Beirut, Lebanon. I'm also the managing director of the Egyptian Dental Center, a multi-speciality discipline dental and maxillofacial center based in Cairo, Egypt. And we are talking in this video about the principles of management of maxillofacial infection. What are the general topics or our ILOs? Knowledge of the general principles of management for maxillofacial infection. Understand healthcare quality parameters. Knowing Al-Shulkami's protocol for quality and patient safety. Understand the management protocol algorithm. Principle number 1. First, we should determine the severity of the infection through complete history and physical and clinical examination. Second, evaluate the patient's host defense status. And this is done through review of medical conditions that might compromise the host defense, review of pharmaceuticals that compromise the host defense. Third, we should determine whether the patient should be treated by a general dentist or referred to an oral and maxillofacial surgeon. Fourth, treat the infection surgically, and this means operatory intervention, whether by extracting or eradication the cause or the offending tooth, or by doing endodontic treatment and keeping the tooth if it is restorable. Fifth, support the patient medically through giving good nutritional and fluid support, multivitamins. If the patient needs hospitalization or even admission into the ICU, this should be done. And last but not the least, choose and prescribe the appropriate antibiotic. And this should be the last resort, not the first. When we face cases like maxillofacial infections, these cases lie in the zone between the dental and the medical sectors, and so we need to review the healthcare quality parameters. First of all, safety should avoid harm to the patient from the care that is intended to help him. Second, the quality of the health care should be effective, providing services based on scientific knowledge and scientific evidence to all who could benefit and refraining from providing services to those not likely to benefit from it. That is to say, avoiding underuse and misuse respectively. Third, it should be patient-centered, which means providing care that is respectful and is responsive to individual patient preferences, needs, and values. And we have to make sure that patient values guide all the clinical decisions. Fourth, it should be timely. That is to say, reducing waste and sometimes harmful delays for both those who receive and those who give care to the patient. Fifth, it should be efficient, which means avoiding waste including waste of equipment, supplies, ideas, and energy, and particularly time. Last but not the least, it should be equitable, which means providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. And accordingly, I've provided a protocol from the quality perspective for management of cases of maxillofacial infection, concentrating on patient safety. And I called it the 6Ps protocol. It starts with prepare, predict, proact, protect, prevent, and finally prescribe. So starting with preparation, what and who should be prepared? We should be prepared with equipment and logistics regarding ORs, ventilators, endotracheal tubes, proper armamentarium, incision blades, sutures, drains, hemostats, mosquitoes. Human resources should be recruited, proper human resources, good otolaryngologists or good surgeons experienced in tracheostomy to perform it as an emergency measure. Continuous training of the staff, whether the surgical or the anesthetist who are going to deal with the case. Predict. Sometimes maxillofacial infection cases might be tricky and they might deteriorate rapidly before you can even think or blink. So what are the predictor factors that might suggest for the operator that this case is going to deteriorate, or the criteria for referral to an oral maxillofacial surgeon for further advanced care? First of all, we have difficulty in breathing, and dyspnea, stridor, dysphagia, dehydration, moderate to severe trismus where the interincisal opening is less than 20 millimeter, any swelling extending beyond the alveolar process into the facial region, elevated body temperature greater than 101 Fahrenheit or 38 Celsius, severe malaise and toxic appearance, compromised host defenses, need for general anesthesia, and last but not the least, failed prior treatment. These are all factors suggesting that this case might deteriorate into further serious sequelae. So what are the clues that might tell you that you need to go to the operating room, for example? When you need to establish an airway security, in cases of moderate to high anatomic severity, when we have multiple space infection involvement, and in cases of rapidly progressing infection, and of course when we need general anesthesia to manage the case. Here are some conditions that might be predictor that the course of the infection might go to the deteriorating phase. What are the compromised host defenses cases? Uncontrolled metabolic diseases like poorly controlled diabetes mellitus, and you can detect this by doing the glycated hemoglobin test, the HbA1c. Patients having alcoholism, malnutrition, end-stage renal disease, other immune system suppressing diseases like human immunodeficiency virus, HIV or acquired immunodeficiency syndrome, lymphomas and leukemias, other malignancies, congenital and acquired immunological disorders. And last but not the least, immunosuppressive therapies or drugs like cancer chemotherapeutic drugs, corticosteroids, and organ transplantation drugs, and on top of which comes the cyclosporin A. A paper was published in 2017 in the British Journal of Oral and Maxillofacial Surgery talking about predictive factors of hospital stay in patients with odontogenic maxillofacial infections, the role of C-reactive protein. And it had been concluded that the concentration of C-reactive protein was a significant predictor of hospital stay, and its measurement on admission can predict the likely duration of stay of these patients. And bearing in mind the serious and fatal complications of orofacial infections, such as cavernous sinus thrombosis, mediastinitis, brain abscess, Ludwig's angina and airway embarrassment, and last but not the least, necrotizing fasciitis. So if you keep an eye on your patient and monitor closely any signs and symptoms suggesting that the course of the disease is going towards any of these complications, like for example periorbital edema and ophthalmoplegia, which is paralysis of the muscles of the eye of the orbit, it might suggest that a cavernous sinus thrombosis is being in process. Chest pain and interference with the function of the heart and the lungs might suggest mediastinitis. Increased intracranial pressure and vomiting might suggest brain abscess in process. Of course, difficulty in breathing and difficulty in swallowing, stridor, and dyspnea might suggest that Ludwig's angina is going to embarrass the airway and close the airway through displacement of the pharynx and displacement of the tongue or posterior tongue and edema around the epiglottis. So keep in mind this and watch the signs and symptoms before they further deteriorate. And so accordingly we need to prevent, of course, prevent any post-operative infection, nosocomial infection, which is infection acquired in healthcare facilities and hospitals, avoid further spread of infection, and avoid deterioration of cellulitis cases, and last but not the least, avoid going into fatal sequelae like the ones previously mentioned before. Proact. In dealing with infection cases, we should always be the ones who take the initiative, and we should be one step or few steps ahead of the course of the disease. So when the disease tries to make a bad surprise for us, we are going to be prepared and we are going to be there waiting for it. First of all, don't let the sun set on undrained pus. Incision and drainage should be done promptly as long as it is indicated to be done. Then, taking the decision for hospitalization or not, refer to the maxillofacial surgeon or call for help or recruit someone to perform tracheostomy or perform incision and drainage if you cannot do that. Last but not the least, removal of the cause. It is very crucial and should be done as soon as possible. The sooner the better. The delay might be very expensive. Protect. First of all, the airway should be protected either by emergency tracheostomy or by giving massive intravenous antibiotics in cases of Ludwig's angina, or if the case does not develop or did not actually develop into Ludwig's angina, we should take care to prevent further development. Protect against intracranial spread, whether it goes into the cavernous sinus thrombosis pathway or the brain abscess pathway. Protect the patient against spread to mediastinum. Treat infections in the lateral aspect of the pharynx vigorously. Protect the patient against antibiotic abuse and bacterial resistance. Some patients tend to take antibiotics without prescription, and they take short course, few days, and then they stop before the clinical signs improve. So antibiotic abuse should be completely stopped, because if bacterial resistance develops, it will be very difficult to treat afterwards. We should protect the patient and improve his health and immunity as well. Last but not the least, prescribe. We need to prescribe the appropriate antibiotic, which is based on the knowledge of the microorganisms or the microflora causing the maxillofacial infections. We can prescribe the antibiotic specific for these types of microorganisms. What are the indications for therapeutic uses of antibiotics? In cases of swelling extending beyond the alveolar process, cases of fasciocellulitis, cases suffering from trismus, lymphadenopathy, fever higher than 101 Fahrenheit or 38 Celsius, severe pericoronitis, and last but not the least, osteomyelitis. So we give the initial treatment of antibiotic and then wait for the response. However, Some instances we need to be more specific and we need to do culture and antibiotic sensitivity testing to decide the specific type of antibiotic. So if we decide to do the culture sensitivity testing, we need to stop any antibiotics have been given for at least 48 hours to get a good and sensitive testing. So what are the indications for culture and antibiotic sensitivity testing? These are infection spreading beyond the alveolar process, in cases of rapidly progressive infection, in case of previous multiple antibiotic therapy and no response, in non-responsive infection cases for more than 48 hours, in recurrent infection, and last but not the least, in cases of compromised host defenses. So we need to be more specific. So to wrap it up, we need to know the objectives of strategic infection management protocol, which are stop the spreading of the infection, eradication of the existing infection, of course, removal of the cause, improve the patient's resistance and immunity through supportive treatment and bed rest, improve systemic symptoms, toxemia, fever, and whatsoever, pain relief, and of course, security and protection of the airway, and last but not the least, prevent deterioration into fatal sequelae. And now let's review the general maxillofacial infection treatment algorithm. Let's start on the left-hand side, receiving the patient and taking history and physical examination. Most probably you will find among the complaints pain, swelling, fine caries, periodontitis, and pericoronitis, suggestive of odontogenic infection. Then, on ordering X-ray examination like periapicals or panoramic X-ray, we are going to find periapical pathosis, obvious periodontal bone loss, or impacted teeth. Furthermore, we are going to assess the severity of the case. Is there any airway compromise? Is the anatomic location of the infection suggesting further deterioration into serious sequelae? How about the rate of progression? And evaluate the host defense through history and pharmaceuticals being taken by the patient. Are there any medical comorbidities, immunocompromised or systemic problems? And if these factors are not in the favor of the patient, we should refer to oral maxillofacial surgery and consider hospitalization of the patient. On the other hand, if the patient is liable to be treated on outpatient basis, we are going to proceed. And it is either of two scenarios. If the abscess is in the early stage, inoculation stage, we are going to remove the dental cause through extraction or endodontic therapy and irrigation and debridement. On the other hand, if it is in the late stage or cellulitis stage, we are going to perform incision and drainage according to the criteria mentioned in the incision and drainage video, and in addition to removal of the cause as well by extraction or endodontic therapy and debridement. In both instances, oral antibiotics are going to be given, good hydration and good nutritional support and multivitamin support and supportive care, patient rest, and control of any systemic conditions. If, for example, we have uncontrolled diabetes mellitus, it should be corrected by the physician as well. And finally, if we have improvement by 72 hours, decrease in fever and the body temperature, and subside in the swelling, so we are going to perform follow-up and preventive and restorative care. On the other hand, if you have failure to improve within the coming 72 hours, we should resort to referral to an oral maxillofacial surgeon or consider further hospitalization and further measures to be done for the patient. Louis Pasteur once said, "Science knows no country, because knowledge belongs to humanity and is the torch which illuminates the world." Finally, I would like to thank you for your kind attention. Thank you so much.